Hello, everyone, and welcome to the Alamo Advocate Program. I am so happy to be here today. I am Laurie Hutcheson, a 7-year survivor of early-stage lobular breast cancer and Executive Director of the Lobular Breast Cancer Alliance, LBCA. LBCA is a patient advocacy organization formed in 2017 by lobular breast cancer patients to raise awareness and educate about the troubling characteristics of invasive lobular carcinoma, ILC, and to promote, and when we can, to fund lobular breast cancer research. LBCA is now the #1 source of scientifically vetted information about lobular breast cancer, and we are committed to ensuring that lobular breast cancer research always includes the patient perspective. You can find our educational resources for patients and information about ILC-focused clinical trials at lobularbreastcancer.org. And it is now my great pleasure to introduce Dr. Rita Mukhtar, who joins me today in addressing lobular breast cancer and its therapeutic challenges. She will be providing an overview of lobular breast cancer and will discuss treatment and imaging challenges in early stage and metastatic lobular breast cancer. Dr. Mukhtar is professor of clinical surgery in the Division of Surgical Oncology at the University of California, San Francisco, UCSF. A long-standing member of LBCA's Scientific Advisory Board, Dr. Mukhtar leads the UCSF Lobular Breast Cancer Research Program. Her work focuses on locoregional management of lobular breast cancer, neoadjuvant approaches, and new methods of evaluating treatment responses, such as circulating markers and surveillance. Welcome, Dr. Mukhtar.
Thank you so much, Laurie. It is really a pleasure to be here.
So my first question is about how lobular breast cancer is different from other types of breast cancer. And in discussing this, can you talk about how it's diagnosed? And I'll pull up a slide while you're talking that shows the differences between the tumor types.
Yeah, absolutely. So, invasive lobular carcinoma or lobular breast cancer is the second most common type of breast cancer. It represents about 10 to 15% of all breast cancer diagnoses. Lobular breast cancer has some really unique features. The main difference between lobular and ductal cancer really is derived from a biological difference where the lobular breast cancer cells are missing a protein that's called E-cadherin. E-cadherin is a protein that normally allows cells to stick together. So this is an adhesion protein. Because lobular breast cancers are missing this protein, the tumor cells don't stick to each other as well as they do in other tumor types, like invasive ductal carcinoma, which is the more common kind of breast cancer. Because the cells are not sticking together, they tend to grow in a more spread out or diffuse pattern. So the pathologist will often see that the tumor cells are growing in single file lines. So that's illustrated here in these graphics, where you can see the lobular breast cancer cells are growing in single file lines, whereas the ductal breast cancer cells are actually forming more clumps or ductal-like structures. There are some other differences between lobular and ductal breast cancer in terms of how often they have hormone receptor positivity, the way that they show up on imaging studies. You mentioned how are these tumors diagnosed? Oftentimes, these tumors are identified on imaging, like screening mammograms, but it is more difficult for screening mammograms to pick up lobular breast cancers because they're growing in these single file lines. Often it doesn't create a mass or something that actually shows up on a mammogram.
Thank you. So now I'm going to ask you to talk a little bit about the challenges of surgery and early stage invasive lobular carcinoma.
Sure. So, for breast cancer, we know that surgery is one of the main treatments for early stage breast cancer, where we want to remove the tumor from the breast and typically evaluate at least a couple of lymph nodes, often through a procedure called sentinel lymph node biopsy. When we remove the tumor from the breast, most people have the option of either undergoing a partial mastectomy, which is known as lumpectomy, or undergoing a mastectomy, which is removing the entire breast, which can be followed by reconstruction, or a person could choose to go flat, depending on their preferences. When we're doing surgery for any kind of breast cancer, we have to make sure that we get the entire tumor out, and the edges of the tissue that we remove, we hope that those edges are clear. So the edges are called the margins, and we're hoping for clear margins. For lobular breast cancer, getting clear margins is especially difficult. And this can happen for a couple of reasons. One, the tumor can have little extensions around it. So even if these lobular tumors have a more central area where there's a denser amount of tumor cells, those single file lines that we saw on that graphic can extend out from that central area of tumor. And often those extensions do not show up on imaging tests. We tend to try and use even better imaging than mammogram if we can when planning surgery for lobular breast cancer. So oftentimes breast MRI can be used. Breast MRI may show the true size of the tumor better than mammogram and ultrasound, although even breast MRI is not a perfect test for lobular breast cancer. But one of the big issues is that oftentimes the surgeon is going into the operating room not knowing the true size of these tumors. So you can end up removing an area that's not quite large enough to be able to get clear margins. If you don't get clear margins, then the patient has to undergo a second operation. So go back to the operating room, try and remove more tissue. This could be done through a re-excision. Some people will choose to go ahead and have a mastectomy at that point. And we do see that patients who have lobular breast cancer have significantly higher rates of both re-excision surgery, so multiple operations, as well as higher rates of mastectomy than patients who have invasive ductal carcinoma. For the lymph nodes, we see similar findings where there's just more extensive surgery that's performed for patients with lobular breast cancer. Because the tumors are much harder to find on screening mammogram, when people with lobular breast cancer are finally diagnosed, the tumors are typically larger and there's often more lymph node involvement, so more positive lymph nodes. This means that when the lymph nodes are removed, oftentimes a full axillary dissection or removing the majority of lymph nodes in the armpit area or the axilla might be needed. And this can cause a lot of morbidity for people. So the more lymph nodes you remove, the higher the risk of developing lymphedema. So this surgical management of lobular breast cancer really has a lot of room for improvement. And ultimately, the problems are rooted in the fact that the tumor grows diffusely, may spread to the lymph nodes, and may grow without being detected. So by the time we're going to the operating room, we have larger tumors, and we don't even know how big these tumors are until we've done the surgery.
A lot of lobular breast cancer patients hear about the issues with imaging, and I know that sometimes they may want to have the breast removed. Can you address the relative risks and overall survival data that you discuss with patients when helping them choose among their surgical options?
Absolutely. So deciding between a lumpectomy and a mastectomy can be very challenging. Um, there are reasons that sometimes people, don't have much choice in the decision. So if a tumor is very, very large relative to the size of the breast, sometimes it's just technically not possible to be able to get the tumor out without doing a mastectomy. If a person has a genetic mutation, and we do see genetic mutations in patients who have lobular breast cancer, and I'll just give a little side note that there is a specific genetic mutation that can cause lobular breast cancer. So a germline mutation in the gene CDH1 is actually something that can predispose someone to developing lobular breast cancer and a type of stomach cancer called diffuse gastric cancer. Having said that, the CDH1 mutation is quite rare. So the most common mutation that we see in patients with invasive lobular carcinoma is actually BRCA2 mutations. If a person has a genetic mutation that predisposes them to developing breast cancer, we often talk about doing mastectomy and maybe even prophylactically removing the opposite breast because the chance of developing breast cancer again is so high. But apart from those two scenarios, most people end up having to choose between lumpectomy and mastectomy. We know that with lumpectomy for lobular and ductal breast cancer, typically this will be followed by radiation. Lumpectomy and radiation are equivalent to mastectomy in terms of risk of recurrence as well as survival. But there is a caveat. Lumpectomy and radiation are equivalent to mastectomy if you get clear margins. So, as long as a person with lobular breast cancer is aware that they have a higher risk of maybe having to have a second surgery or a re-excision, it is perfectly safe for people to choose lumpectomy as their option. There are certain surgical techniques that can help reduce the risk of developing positive margins for people with lobular breast cancer. So work has been done looking at the technique of using or taking what are called shave margins. Shave margins means that at the time of lumpectomy, additional portions of tissue are removed. It's essentially doing the re-excision surgery at the same time as the initial lumpectomy. And that is something that I think should be done for all patients who have lobular breast cancer that are undergoing lumpectomy, because this can reduce the odds of positive margins by about 60%. Another technique that can be quite helpful to reduce the chances of having positive margins is doing what's called oncoplastic surgery or oncoplastic techniques. Oncoplastic surgery involves rearranging the tissue inside the breast to be able to fill the gap that's left from a lumpectomy. This allows the breast surgeon to remove a larger portion of tissue and still have an acceptable result in terms of how the breast looks at the end of surgery. And oncoplastic surgery can be done by a breast surgeon who has been trained in oncoplastic techniques, or could be done by a breast surgeon in conjunction with a plastic surgeon, just depending on the particular practice type.
So it sounds like if someone has lobular breast cancer, maybe opting for a lumpectomy, that maybe they should find out whether their breast surgeon has that special training.
I think that that would be a good question to bring up.
Great. Well, so I want to ask you a couple of imaging questions. Imaging is a huge issue for lobular breast cancer patients, and with respect, and you started to touch on it with respect to surgery, and I'm wondering whether an MRI is always recommended before surgery with a lobular breast cancer patient.
In my own practice, I do use MRI before surgery because I think that that gives the best picture, the clearest picture of the tumor. And oftentimes we do find that the tumor is much bigger on MRI than what we thought it was based on the mammogram and the ultrasound. Whether it's recommended for every patient is a little bit less clear because there's been some mixed data. So when people have done research studies looking at whether MRI is helpful for patients with lobular breast cancer, there are some retrospective studies that show that there's no difference in the rates of positive margins when people have an MRI versus don't have an MRI before surgery. There are some studies that show that if you get an MRI, this might lead to higher rates of mastectomy. And it's unclear whether those higher rates of mastectomy occur because the MRI might have false positive findings. People end up having to go through biopsies. Sometimes going through a lot of biopsies can make people have some biopsy fatigue and maybe make a decision, let me just go ahead and do the mastectomy at this point. Maybe the MRIs are actually giving us useful information that the tumor is so big that it's not worth trying a lumpectomy first. It's difficult to sort out these issues. I will say that there was a more recent study where the investigators tried to match the patients who got MRIs and didn't get MRIs, to pick patients who were as similar to each other as possible. Because you might say, well, maybe people are using MRI in the more difficult cases where it's more difficult to see on mammogram. And if it's more difficult to see it on mammogram, and that's why we're getting the MRI, maybe that's why we're still having the high positive margins, because the tumor was so difficult to see no matter what imaging test you get. When people do these matched analyses, it does appear that MRI is associated with lower risk of positive margins and lower rates of re-excision. So I do think that we have enough data to support the use of breast MRI for patients with lobular breast cancer when planning surgery. There are many professional organizations and societies that do endorse the use of breast MRI before surgery for those with lobular breast cancer. There are some scenarios where MRI just is not going to be feasible. So people who have kidney disease, so the MRI does use IV contrast, it's gadolinium. So if there's severe kidney disease, a breast MRI may not be a safe thing for someone to do. The MRI does require laying on your stomach face down, typically going inside a tube. Some people who have severe claustrophobia really cannot tolerate that. There is this issue of sometimes the MRI does show findings that are not cancer, but it's impossible to tell without doing a biopsy. So when someone is undergoing a breast MRI, they might find themselves in a situation, maybe 10 to 20% of those patients might find themselves in a situation where they end up having to undergo another biopsy before surgery that might end up being benign, but we didn't know it until the biopsy was done. So, like I said at the beginning of this part of our conversation, I do like to get breast MRI before surgery. But if I ever have a patient who says, I really don't want to do it, I think that's okay. But I go into the surgery knowing that the tumor is probably a lot larger than what the mammogram and ultrasound indicated. And then we can compensate for that as long as we go in knowing that.
So it sounds like perhaps because of the imaging issues that monitoring or surveillance in general with an MRI might be recommended even after initial therapy, or whether somebody has now moved into their systemic therapy and, instead of just an annual mammogram, maybe you would recommend an annual MRI. And also, what about when their systemic therapy is done completely?
Right. These are really good questions, and we need much more data in lobular breast cancer to really answer those questions well. We have a little bit of data, as you are suggesting, um, recurrences that happen after local therapy and either during systemic therapy or after completion of systemic therapy, which could last 5 to 10 years, as you know, with the hormone blocking medication. Recurrences for lobular breast cancer can be difficult to see on mammogram. We looked at our population of patients with lobular breast cancer at UCSF, and we found all of the patients who had early stage lobular breast cancer and had a recurrence in the breast area or in the lymph node area, so what's called local or regional recurrence. And we went back to their charts and we tried to figure out, how was this recurrence found? Did the person themselves feel it? Did their physician or nurse practitioner or someone examining them feel it? Did it show up on a mammogram? If they were getting MRIs, did it show up on an MRI? And what we found was that for people who were only having mammograms as their surveillance imaging, most of the recurrences were actually found because either the patient or their physician actually felt it. So they felt something that was abnormal, and then that prompted imaging. So the mammograms didn't pick up these recurrences in many of those patients. For the small number of patients that were having MRIs as part of their surveillance, if they had a recurrence, most of those recurrences were found by the MRI. So I do think that breast MRI should be considered in surveillance of people who undergo treatment for early stage lobular breast cancer. But certainly we need more data to really look at the outcomes of what's sort of the pros and cons of doing it long term. How many years do you do it? We don't know when to stop doing it. We don't know how frequently to do it.
Great. So now my final set of questions are going to be about metastatic lobular breast cancer treatment challenges. And I'd like to have you tell us a little bit about what those challenges are, how you monitor whether a line of drug is working, and the imaging challenges. And I'm just going to put up a slide of the different places where ILC cancer might metastasize to.
Certainly. So metastatic breast cancer or stage 4 breast cancer, as we know, this means that cancer has spread beyond the breast and lymph nodes, and has gone to a different organ of the body. With lobular breast cancer, we see a different pattern of metastatic disease than what we see in ductal breast cancer. Some of the sites are in common, but some are different. Lobular breast cancer tends to metastasize to organs in the abdominal cavity. And this is a unique feature where we can see lobular breast cancer going to the stomach, to the intestines, to the lining of the abdomen, which is called the peritoneum, to the fatty layer that's in front of the intestines, which is called the omentum. We also see lobular breast cancer go to the ovaries, as well as other sites that are less common in other kinds of breast cancer, such as the eye socket. Lobular breast cancer can also go to more common sites like the bone, the liver, the lungs. But we definitely see that there is a difference in where these tumors tend to go. When there is lobular breast cancer that goes to abdominal organs, this can cause problems with developing fluid around the intestines, and that's called ascites. Just like lobular breast cancer grows diffusely in these single file lines when it's in the breast, when it metastasizes, it also tends to grow in a more diffuse pattern. So instead of forming these solid balls of tumor or a mass of tumor, it may grow more in sheets or in this liquid form like ascites around the intestines, or fluid around the lungs, or fluid around the heart. This can lead to challenges in measuring how much tumor is there. And when it comes to clinical trials for metastatic breast cancer, it's very important to be able to measure how much tumor is there, because that's how we know whether or not a certain treatment is working. So patient has a certain amount of tumor in the body. This is often measured using something called RECIST criteria. RECIST criteria means you take a site of metastasis, say the largest site of metastasis, and you literally measure on a CT scan or maybe with calipers, what are the dimensions of that tumor deposit or that metastatic site. Then the patient gets a certain treatment, and then you measure that site again, and you see, did that tumor shrink or did it get larger? And RECIST criteria really were developed to have an objective way of determining whether or not treatments are working, and that is really important for clinical trials. But the problem is that if someone has metastatic breast cancer that doesn't form a solid mass somewhere, and it's growing in sheets or growing diffusely or creating fluid, you can't measure it with a ruler. So that is called unmeasurable disease. And people who have unmeasurable disease may not be eligible for clinical trials, because one of the eligibility criteria is we have to be able to measure the disease. We actually looked at the rates of enrollment on clinical trials for patients with lobular breast cancer at our own institution, and we found that for early stage, patients with lobular breast cancer were just as likely to be on a clinical trial as patients with ductal breast cancer. But for stage 4 or metastatic, those with lobular breast cancer were significantly less likely to be enrolled on a clinical trial. And we believe that it's because the majority of clinical trials for metastatic breast cancer do require measurable disease. Not being able to enroll in clinical trials is a big problem, because stage 4 trials is how we find treatments for people with stage 4 cancer. And if we're not enrolling patients with lobular, we're not going to find treatments that are effective for lobular breast cancer. And if there is a trial that might be specifically effective for lobular breast cancer, we won't know that it's effective if we don't have enough patients with lobular breast cancer enrolled in that trial. Additionally, enrolling in clinical trials is actually associated with longer survival in the setting of stage 4 disease. So, this really can have a major impact on people who have lobular breast cancer. There is work ongoing to try and identify different imaging tools that might be better at seeing metastatic disease for those with lobular breast cancer. Most of these tumors are strongly estrogen receptor positive, so there are PET scans that can use a new tracer called fluoroestradiol or FES. There's a PET tracer called FAP, which is looking at fibroblast activating protein, and this might be a promising imaging tool for lobular cancer. There are people working on whole body MRI. So I think that the tools that we have right now have limitations in lobular cancer, plus the pattern of metastatic disease can really lead to problems in terms of enrolling on trials.
Yeah, I imagine even if you're not contemplating a trial and you have metastatic lobular breast cancer, it must be hard to monitor whether a drug is even working because you can't necessarily tell. Um, can you tell us about your Plum study for patients with metastatic lobular breast cancer, which I
Yeah.
think is currently open, right?
The study is open. So, this issue of people not being able to enroll on metastatic trials actually led us to develop a study called the Plum study. And I want to mention Julia Levine, who unfortunately passed away from metastatic lobular breast cancer. But it was Julia who played a key role. She was a patient advocate who played a key role in the design and development of the Plum study. The idea of the Plum study is, well, if we can't rely on imaging to measure how much tumor is there for someone who has metastatic lobular breast cancer, maybe we can use new technology such as circulating tumor DNA or ctDNA. ctDNA is a blood test. It measures the amount of tumor DNA that's in the blood. And with some of these ctDNA tests, you can actually quantify or measure how much tumor DNA is in the blood. So you can see the levels going up and down over time. It's not known whether we can use this test to reliably determine whether treatment is working or not. So the idea of the Plum study is for patients with metastatic lobular breast cancer, we are measuring their circulating tumor DNA levels every time they have an imaging study, and we're asking their medical oncologist to fill out a survey that's telling us, does the medical oncologist believe that treatment is working and the tumor is quote unquote responding, or do they believe that the treatment is not working and the tumors are actually growing, or the metastatic disease burden is increasing? What we hypothesize is that the level of ctDNA will accurately reflect whether a certain treatment is working. And if that's true, then ctDNA could be a way that we measure tumor response that could allow for people to enroll on clinical trials, even if their disease is not measurable on imaging. It could also allow for people to not have so many CT scans. So maybe have a blood test, only get the CT scan if the ctDNA level is rising. The Plum study is funded by the Metaviver Foundation. It is open at UCSF. We are amazingly almost halfway done with enrollment already. We've had so many patients who have been very eager to enroll on this study. And we are opening the Plum study with our collaborators at UC San Diego, University of Pennsylvania, as well as MD Anderson. And hopefully those sites will be opening in the coming months.
Well, that's fantastic. And I can't wait to hear how it goes. And I think that's a really great note to end on. And I want to thank you so much, Dr. Mukhtar, for speaking with us today. And thank you to the Alamo Advocate Program for having us and for all of you for being here.
Thank you so much.